and Professor Türe, we will talk with Professor Türe about his thoughts and his tips and tricks about these things. Professor Türe, do you want to share some things about these things and what are your main principles when application of pinhead holders?
It was an excellent, thank you very much, first of all, for the kind invitation. And it was an excellent talk from Dr. Adnan. I am agree in some point, but I don't agree in some point. So may I show you some slides?
Sure, Professor.
I cannot share.
Imad, can you help there? Hi, Professor Türe, how are you?
Hi, how are you? Thank you.
Sir, you are already allowed.
Yeah, but I cannot share. What's wrong with that?
I think then you have to rejoin.
If
Pardon?
you could just if you could exit and just come back in, sometimes Zoom does that. If you can just exit and come back in straight away, please. We'll get you up straight away.
Now. Okay, sorry.
Okay. Abuzer, you want to say a few words since we have a few seconds?
And also, I have a talk about the usage of interpret ultrasound, and also I used the ultrasound in AVM cases to show the drainage and feeders of the AVMs, and also putting some temporary clip to feeders and check again with the ultrasound. I think it is too helpful to use ultrasound in AVM cases. Could you share, Professor?
I think there is something wrong in the system setting.
Imad, can you check again, please?
Sir, he has to allow from his laptop.
Yeah. I have to. Yes. Yeah. Can you see this slide?
Yes, sir.
Yeah.
Here. So I use Mayfield pin holder. I know Sugita system. I try to use. I know one of my mentor, Dr. Ernest Niemi, loves this system, but I couldn't use it. It's very complicated and it's obstructing my surgical ability. And I love Mayfield system. But there is a problem in the Mayfield system. First of all, this description of Professor Yaşargil is very clear that where we have to put the pins of the 3-pin Mayfield, never put in the temporalis muscle and never put in the suboccipital muscles. And also we have to be aware about the nerves, cranial nerves. But it is the scalp nerves. It is interesting. In the website of the Mayfield, they show that how we can use the Mayfield. For example, this is from the website of the Mayfield system. But these pins are in wrong places. This is in the temporalis and here. Yeah, so in my opinion, this is wrong usage of the Mayfield system. And this is also never put this way. This is also wrong description of the Mayfield system. And this is also wrong. For the pteronal approach, I prefer to use one to the mastoid. Mastoid is the safest place to put the one pin. and then you can use other. So this is also, I just use in opposite way. I never put this pins here. I never put this pins here. This is first pin we can put in the mastoid, and then the other one in the frontalis. Never put here, never put in suboccipital space. And I'm very happy to use Mayfield, but I have to follow the rules that we have to put the pins in the thick bone and never in the muscle. And this is the positioning of the patient. I think this is safe and good positioning for the pteronal approach. In any other approaches also for the semi-sitting position, the same rule, or lateral position, same rule. This is not rare. Look at here. This is not rare. This may happen. And this can be the disaster because when you put a pinhole here, you may have it. And the picture of the Sugita system also shows the frame, but that frame also passing through the temporalis muscle and the squamous part of the temporal bone. So this is most critical issue. But I have another problem now. Because Mayfield system, I now use intraoperative MRI routinely. And Mayfield system doesn't work. And Sugita doesn't work also in the intraoperative MRI. And unfortunately, I have to use this system for intraoperative MRI, which there is no better one. I hope new ideas, new companies will give a better options for intraoperative MRI, but this is very complicated. I don't like it, but I have no better choice for intraoperative MRI. So this is my thought about the pins. I can stop share. Yeah. I don't hear you.
You're muted,
Do you
please.
prefer navigation or intraoperative ultrasound in your cases?
Neuronavigation or intraoperative MRI? Sorry, neuronavigation or
Intraoperative ultrasound.
ultrasound. So, also I thanks Dr. Azuz for excellent lecture about intraoperative ultrasound. I have all of them. I have intraoperative MRI, navigation, ultrasound, whatever. I love ultrasound. There is no doubt. In brain, navigation doesn't work. And some people says in brainstem it's working because its brainstem is not moving. No, brainstem is moving. Depends of your positioning of the patient. Depends of the case. And some couple of millimeters is enough to destroy something in brainstem. So I do not trust navigation in brain tissue. I use real-time ultrasound. The best navigation is the cotonoid. Cotonoid, very simply, you can navigate with the cotonoid and ultrasound. I love ultrasound. But of course, I use navigation for skull base, for transfemoral surgery, or I will talk about the orbital surgery. Navigation is excellent. When the bone tissue is there, you can use the navigation. Otherwise, navigation is good for resident to put a correct craniotomy. So it's working there. When you put the correct craniotomy, it's working back there. But don't use small craniotomy also for gliomas. For gliomas, someday that patient will need reoperation, and that tumor may come up with the bigger size. So for metastasis, for cavernoma, you can do a small craniotomy with using navigation. Okay, but for glioma, don't try to do also small craniotomy. I think my time is over.
Yeah. So thanks for your tweaks
Yeah.
about the pin holders and the users of ultrasound and all lectures. I think
sorry, can I just ask, have you got any suggestions for young neurosurgeons when they're starting out? Just a quick comment.
Professor Türe.
What did you ask? Sorry.
Have you got any suggestions for young neurosurgeons who are starting out for microneurosurgery?
Oh.
Just in few
They
lines.
have to give their life. They have to put their life. Yeah. Yeah. So they have to study in the lab, in the cadavers, and then they have to see masters. They have to see surgeons from all over the world, different ideas, different perspective, different techniques, tricks. Every master has their own tricks, and so we have to learn all of that, and we have to continue. I am just starting neurosurgery. I am just starting to understand what's going on.
Okay, thank you, everybody.
Correct.
Abuzer, you want to wrap it? Thank you.
Yes, thank you for all lecturers and speakers. I think Professor Yousuf can finalize the session.
Yes, thank you, everyone. Thank you, Dr. Abuzer. Thank you, Dr. Ugur, for the amazing advice to neurosurgeons like me. And so now, thank you to all the speakers, and also Dr. Yousuf and Dr. Atef for moderating.